Good afternoon, everyone. I'm Liz Siegert. I'm AHCJ's core topic leader on aging, and with me today is Tara Haley, medical studies topic leader. This webcast is one in a series of topic-specific training opportunities to brief health journalists on the latest information in a particular health area and to give them story ideas or resources they can use in their work. Today, we're going to talk about covering cancer while balancing facts, hype, and hope. Increased public awareness about screening guidelines and cancer symptoms, paired with greater willingness to talk more openly about cancer than in the past, have meant more disease is caught at earlier stages than it once was. This makes it more treatable and increases the odds of survival. And people are also living longer with disease. Yet, as the recent controversy over the U.S. Preventive Services Task Force breast cancer screening guidelines showed, the topic of cancer is still fraught with emotion, conflicting opinions, and confusion. Joining us today is Elaine Shatner, MD, a medical journalist and clinical associate professor at Weill Cornell Medicine's Division of Hematology and Medical Oncology. She's a breast cancer survivor and author of From Whispers to Shouts, The Way We Talk About Cancer. And momentarily, we will also be joined by Dr. Mara Gulshan, Deputy Chief Medical Officer of Surgical Services and Clinical Director of the Center for Breast Cancer at the Smilow Cancer Hospital and Yale Cancer Center, who wrote a powerful op-ed for the New York Times when the new guidelines were announced. Our guests will present and then answer your questions. Please use the Q&A at any time to type them in. We'll be able to see them, and either Tara or I will direct them to our panelists. So let's get started. Elaine, let's hear about cancer communication and why we need to talk more about it.
Sure. I'm going to share my screen. Okay, so hi everyone, and thanks so much, Liz and Tara, for inviting me to speak today. I have just 15 minutes, so with that, I'm going to give you just sort of an overview of my book, a taste of what it's about, and talk about some of the issues in reporting on cancer from my perspective as a former practicing oncologist and as a person who's had breast cancer. So first, this is an image of my book, which I hope you might find of interest. One of the threads in the book is the history of cancer journalism. And basically, I think that if I had to pick one story that led me to write the book, it was this. An article that appeared in the 1913 Ladies' Home Journal, penned by a journalist, Samuel Hopkins Adams. I'm using the cursor now. Do you see that? Probably not. Okay. So Adams was and is known as a muckraker. And he was a prolific author. And what's interesting about this article, among other things, is that he worked together with cancer experts in the progressive era to inform the public about cancer. So even though he was a muckraker, he basically wrote down what doctors told him and shared that information. And this article, which appeared in the May issue, goes into enormous detail about best cancer treatments. Adams reviewed the 7 most common tumors, what kind of surgery was warranted. He cautioned people against going to bogus doctors offering painless cures. He advised second opinions. For instance, if a woman had a breast lump and a doctor told her she was too young or it was nothing to worry about, he advised going for a second opinion to that it be examined under a microscope. And in some ways, he was very forward-thinking about the patient's role in decision-making, and then that people should be informed about their conditions. The Ladies' Home Journal we think of as a glossy that's no longer published, but the fact is in 1913, before television, obviously, and even before radio, magazines were a really important way for the public to find out about health. And so this was a groundbreaking article. You can see it was sort of made tasteful with this lattice floral border. And I should mention also that this article appeared with a stamp of endorsement, essentially, by Dr. Thomas Cullen. And he was a gynecologist at Johns Hopkins Hospital. And he was among the expert physicians who enlisted the journalists to write about cancer so that people would be less afraid of surgery and that they would come earlier when cancer they thought was curable. Whether it was curable with surgery in 1913 is debatable. The fact is almost all cases, including breast cancers, were not curable in 1913, unless they were caught like super, super early. Most people died after breast cancer surgery in 1913 and for half a century later. I found it of interest, and I think you might, that cancer was a public health issue. So these posters were published by the US Public Health Service, along with the early American Cancer Society, to inform the public about the disease. And the idea, which comes up in other posters, of fighting cancer with knowledge, really is about people knowing that if they came in early, when a tumor was small, for example, a skin cancer or a throat cancer or a breast lump, that then it could be treated effectively. But if they came in late, if they shied away from legitimate physicians, they were doomed. So this is really early public health messaging about cancer. And okay, the point of this slide is that there was a lot of misinformation and fear of cancer and its treatments, and fear also of hospitals, institutions where cancer was treated. So, you know, the idea here is that misinformation is not new. This is the cover of a brochure that I found in the Rockefeller archives. It's about a hospital in Eureka Springs, Arkansas, Castle in the Air, which was run by a Mr. Norman Baker, who his medical historians have described as the king of quacks. And people might go there, he advertised, to get well with cancer and other non-communicable diseases without surgery, radium, or x-rays. So this, you know, there was a lot of misinformation. In my book, I go through many instances of that. One of the threads of my book, besides journalism, is the role of women in distributing information about cancer. And really, one of the heroes is Dr. Anna C. Palmer, who was treated for breast cancer in 1920. And in 1938, as a retired physician, she formed what was called the Cured Cancer Club. And the club is, to me, I think it's the first instance, at least that I know of a nationwide peer patient organization for people who've had cancer. But what Dr. Palmer's purpose in forming the club was not to meet other patients or for camaraderie. Rather, she aimed to persuade the public and also her peer physicians that cancer was curable or at least treatable, because there was a lot of fatalism about cancer. People didn't believe it could be treated. People feared surgery. And she thought, by setting an example, by saying, I have had cancer and I am alive so many years later, in this case, 18 years, she would help persuade people that it was worth getting conventional treatments. To join the club, a person had to survive 5 years after treatment by a so-called legitimate physician. They had to be willing to say their name, provide their address and their diagnosis in public. And that was a big deal because there was a lot of stigma about having cancer. People thought that many people, and even doctors, attributed it to misbehavior, God's wrath. And also many people thought cancer was contagious and didn't want to be near people who had cancer. So she was quite brave when she first started speaking at women's clubs in the 1920s and then formed this. I'll also highlight this infographic, which is one of my favorite images from the book. This was published, as you can see, in 1940, and it was a Cancer Society infographic, and the walking figures represent 20% of survival at 5 years. The tombstones represent 20% of death at 5 years. So the idea is, with early treatment, basically you have a pretty good chance if you have cancer of the breast, womb, or mouth, whereas if you present late with your disease, you're doomed. And cancers of the rectum, it's more like 50-50, and if you present late with that, you know, there's no way. I'll just mention one other fact that journalists might find of interest here. This story, which was an Associated Press story during World War II, syndicated, was penned by C.C. Little, who was a geneticist who led the Cancer Society in the 1930s. He was also a eugenicist. And the very problematic relationship between the early eugenicists and the early Cancer Society is something I consider early in my book. He later became a spokesman for the tobacco industry, by the way. Anyway, but this is a facet. I mean, this is an image. So I'm going to move forward in time to get to the end of my 15 minutes. I think that when Nixon signed the National Cancer Act in 1971, it was a pivotal moment in cancer journalism, because up till that point, there wasn't a lot of mainstream criticism. Basically, Nixon signed this a few days before Christmas, and he did so to raise federal funds for the National Cancer Institute. He didn't actually use the phrase war on cancer, although he's often that phrase is often attributed to Nixon. What's key here is that this was a bilateral, bipartisan thing. Everyone wanted to cure cancer. And many people thought that with US science in the post-war era that we might be able to do it. This is Representative Paul Rogers, a Democrat from Florida, Ted Kennedy, you see, and Nixon, and they're all smiling. And my point is everyone thought it was good, well, pretty much everyone, to increase federal funding for cancer research. So a few years later, in 1975, a credible journalist named Daniel Greenberg published this in the Columbia Journalism Review, an article, a critical look at cancer coverage. And he really called Nixon's effort the war on cancer. And what he wrote, I'll give you this quote, is with the acceleration of the so-called war on cancer now in its third year, it's useful to contemplate certain curious and gruesome parallels that are beginning to appear between the reporting of this war and the early bulletins from Vietnam. And he basically said that the reports on the war of cancer were too optimistic, that the statistics of provided by the Cancer Society and by the so-called specialists, the establishment, were misleading because they were too optimistic. And he felt that journalists were being duped by those statistics. And I see this as sort of the origin of, if you will, the politicization of cancer coverage, which is a theme in my book, and I think is fascinating. So this article a few years later was published in the Washington Post, but there were similar pieces in the LA Times, the New York Times. It became sort of a right-wing cause to support the National Cancer Institute, and that I find puzzling as a women's health advocate and someone who leans left. I'd be remiss if I didn't mention the AIDS epidemic, which and its message of speaking out, and patients really became much more visible with this epidemic. And I think the impact of the AIDS activism on cancer patient advocacy has been unmeasured, and it is huge. That people began to speak, be more visible about their disease, to speak up about their conditions, and to speak up about their needs. What happened also is that more people started surviving cancer. And this is a graph I promised that I would share, Liz, that I would share, because it's about the aging population. Basically, as cancer treatments got better, and I'm really moving forward fast here, more people survived cancer, more people spoke out about having cancer, and more people were older who had cancer. And so you can see here the group 65 to 74 in green, 75 to 84 in purple, and then the really elderly people, that's an expanding cohort of cancer survivors, people who are alive after a cancer diagnosis. And I think it's really fantastic that, there were only 3.6 million known cancer survivors in 1975. Now we have around 20 million, and that number is projected to rise. The problem, which for our society is how to pay for their care, and especially as older patients tend to have other diseases. I think doctors have to be especially careful about prescribing treatments, and also maybe being thoughtful in their approach to older people who have cancer. If people, for instance, are not likely to live much longer because of other, heart disease or other conditions, that really affects the equation of treatments that, whether it's worth treating the cancer per se or not, or just using palliative care. This op-ed appeared in 2018 by Dr. Bob Wachter, whom I respect very much. I don't know if he wrote the title, "The Problem with Miracle Cancer Cures." The issue here, he describes an old woman who comes into the hospital, and she and her family say, well, she has metastatic lung cancer. And a few years before 2018, he would have said, I really think you should go home on hospice care. But thanks to these new immune treatments, he said, he couldn't shrug those off. They asked, what about these immune treatments? Should we try them? And he felt that it was wrong to say no. Basically, the dilemma is now that treatments are more effective and there are more cancer treatments, it's a harder decision for doctors who used to just say, the treatment is not worth it. Now, as treatments become better for cancer, more effective and less toxic, it's a harder discussion for doctors to have because the benefits may be real. A terrific example is that of Jimmy Carter, who was treated for metastatic melanoma in 2015. In August of 2015, he himself held a press conference. He spoke about having cancer quite openly. He got immune treatments. The cancer had spread to his brain and his liver. And it was unbelievable. A year later, he was building homes with his wife for Habitat for Humanity. I mean, that story is incredible to me, as a former oncologist. It makes it hard to say no. Running out of time, I'll make this point, and this is a good lead into the next talk, that breast cancer mortality rates have improved dramatically in the United States since the late 1980s. And there's been progress both in Black women and in white women. This is a graph that was published last year in the New England Journal of Medicine. You can see that progress among Black women and lags still, it's evident. And epidemiologists, almost without exception, attribute this decline in deaths, which is about 36%, 38%, depending on how you calculate it, at the population level. They attribute this to a combination of improved screening and improved treatment. And you can't disentangle those two factors. I would say just also that it's not that Black women had a lower breast cancer rate or fewer deaths from breast cancer before the 1990. Rather, their deaths were overlooked and not counted due to less insurance and just more off-grid care. More people are living with metastatic cancer, and I'll make the point that it's expensive. I'd like to end with this slide just about the possibility of cancer as a chronic disease. So this shows a crab, that's cancer, nipping at Heracles' leg while he fights a greater enemy, the Hydra. And as a society, I guess I like to think of cancer no longer as like the demonic biggest enemy in the world thing it once was, but rather as something that can be held at bay while we fight other problems such as real wars and climate change and other great problems that afflict us. Thank you.
Thank you very much, Dr. Shatner. And I should ask Dr. Shatner and Dr. Golshan, do you have a preference in how we address you? I'm
fine with Elaine.
Okay.
That's what I go by.
Mara is fine for me. Sorry.
Okay. Oh, no, that's fine. So I'm going to introduce Dr. Golshan, or Mara, who just joined us. He's a cancer surgeon who is Deputy Chief Medical Officer for Surgical Services and the Clinical Director at the Center for Breast Cancer at Smilow, I hope I'm saying that correctly, Cancer Hospital and Yale Cancer Center. He recently wrote about the updated breast cancer guidelines in the New York Times and provided a very nice kind of middle ground to understanding the challenge of balancing the risks and benefits and harms that exist with screening, where you have the overtreatment concerns when you detect too much versus not detecting enough and treating cancer that could have been caught earlier and saving lives. And it's a difficult balance there. And it's not just with breast cancer, but multiple cancers. And in fact, Mara himself is a survivor of colorectal cancer, where we also just recently had changed guidelines a couple of years ago. The American Cancer Society reduced those guidelines from starting at age 50 to age 45. So thank you for joining us, Mara. And I guess we'll start. I know you don't have slides, so I'm going to kind of moderate this discussion. Thank you so much. Can you talk a little bit about how you balance that, how do you, what are the harms that are possible with screening, and how do you decide like how many lives are worth how many harms? Like how does that happen, I guess?
So it is if it was a simple answer, I guess I wouldn't be invited, or none of us would be invited here to speak. We often think of answers to science or healthcare questions through clinical trials, but before we even get to a clinical trial or look at long-term data on doing something, mammograms or not, clinical breast exams or not, colonoscopy or not, you have to be able to understand, one, what is the patient population that you're looking at? Here, I think we're focusing on the United States. I also do a fair amount of work in some resource poor areas of the world, outside of the United States. And, when thoughts were being mentioned about, cancer is caused by doing something bad, or, some, religious type concerns, that actually still exists in in some parts of the world, and, are important things that need to be addressed. Then the question is, how many lives is enough lives? And certainly when, I became a patient myself, I didn't want to hear about statistics. I just wanted to know I'm going to live, and, could we have done something differently a little bit earlier? And would that have made a difference in outcome? Now, certainly whenever you do screening, whether it's for, mammography for breast cancer, PSAs, for prostate cancer, colonoscopy for, colorectal cancer, there are risks with some of the procedures. Like with colonoscopy, you can damage the wall of the colon, rare cases of, perforation, things like that. With a mammogram, I've treated thousands of women with breast cancer over my clinical career. I pretty much know that, from what I've heard from, there's never been someone said, oh, it was like a super easy exam. There is always some anxiety going into it. There's pain associated with the compression on the with the mammography. And then if something is seen, or you see the technologist or the radiologist face change, what happens to that patient or person? And I think that's where, we have to look at the sensitivity and specificity, basically the number of, exams that are performed, the number of things that are identified. These things sometimes can be malignant or cancerous, but many times can end up being benign. For me, going through this myself, I would take 1,000 benign, results if I could prevent one cancer. But for many others, that anxiety of having to come back for additional imaging, biopsy, waiting for the results, waiting to discuss the results with a provider, and often it ends up being benign. That does hurt. It hurts in a different way, and we have to take that into account. But we have so much data that shows that breast cancer screening gets cancer at an earlier stage. If you get cancer at an earlier stage, you're going to have better and more treatment options, sometimes a lot less invasive treatment options to consider for that patient and their overall outcome. So it's complex, it's layered. There's not one straight answer, and especially in this realm of breast imaging and mammography, this has gone back so many times, back and forth with different societies, and some say 50, some say 40, some say every other year starting at 40, some say go to a certain age and stop. It's confusing, and I'm not saying that there's necessarily one right answer, but these organizations coming together, I think, makes a lot of sense. If they're going to put something out, that they discuss it amongst each other and then talk about the pros and cons associated with going through a test like a mammogram or an ultrasound, and the possibilities of going through a biopsy and getting a benign result.
in looking at the evidence that's used to make those determinations, in looking at, studies on overdiagnosis or studies on anxiety and whatnot, how robust is that evidence? I mean, are we working with a reliable enough and large enough evidence base, or are there a lot of gaps in that make it more challenging to make make the ethical calls, I guess?
So there have been many studies randomized both in the United States and Canada and in Europe and in a few other parts of the world where there have been tens of thousands of women who have undergone, screening versus no screening, or screening every year versus every other year, or versus clinical breast exams and self breast exams. And there is a increase in the number of cancers that are detected as a woman matures in age. But that's partially because, one, it becomes a little bit easier to interpret the mammogram. Two, breast cancer does occur, the average age in the United States is 61 and a half or 62 for breast cancer. But that doesn't mean that a 40-year-old or a 30-year-old can't get breast cancer either. So you have to kind of weigh the pros and cons of all these approaches. And then, with the most recent guidelines, there have been, a lot of criticisms in terms of certain populations that may not be addressed with a one-size-fit-all kind of policy for it. So we saw in the previous presentation, the more poor outcomes in Black women or African American women. There are certainly hereditary predispositions to breast and ovarian cancer in certain subpopulations that need more stringent guidelines in terms of follow-up and imaging that's associated with more aggressive cancers that could present either at shorter intervals than the yearly recommendations or every other year recommendations. And if it's not caught early in for example, a younger patient, you would have fewer treatment. You would either have more severe treatment options, meaning things like, the addition of not only surgery, but radiation and chemotherapy or drug, various forms of drug therapy to treat the cancer, as opposed to, having, to go through fewer serious treatments.
You at the end there, you were just touching on what my next question was going to be, was looking at this through a health equity lens. What do journalists need to know about the gaps when it comes to specific populations? And that could be racial or ethnic populations, or geographic populations, or nationality populations, or even certain types of exposure populations. I'm thinking, for example, people who were exposed in utero to diethylstilbestrol have a modestly increased risk of breast cancer for a short period, and then it goes down, and it gets really complicated. How can journalists, I guess, communicate those nuances while not confusing or overwhelming our readers?
You're right. I mean, this is in the US, there's a large population, many coming from various different backgrounds. And there is no one size fits all. You were talking about, in utero, there are also many patients at a younger age who may, for example, were treated with for Hodgkin's lymphoma with what's called mantle radiation, or radiation to the chest. And we know in that group, they're at a much higher risk of developing breast cancer. And not only when they develop breast cancer, because they've undergone radiation, sometimes that limits the type of surgical treatments that are offered to them, meaning that many women, in the United States who are diagnosed with early stage breast cancer are offered either lumpectomy or mastectomy. And lumpectomy is just removing the tumor rim of normal tissue, often followed by radiation. But in this group, because they've received radiation in the past, it often obviates, and you could not undergo lumpectomy and often have to undergo mastectomy. And many of the studies that were done really did not have enough patients from different demographics and subgroups to come up with definitive recommendations for them. And they were underrepresented, meaning that we weren't doing a great job at approaching them and offering clinical trials. This is like an area that is a hot button topic. Wish it was decades ago, but certainly is now, of getting groups and patients and populations that are, usually not part of, screening or clinical trials, to have them more and more represented in clinical trials and studies. It's a lot of work to do. The the NIH's and the current NCI's Cancer Center Director, Dr. Monica Bertinoli, who was my division chief when I was at the Brigham and Women's Hospital in Dana-Farber. I know this is one of the main areas that she is focusing on in terms of increasing the representation of those underrepresented groups. Then it's also access to those studies and care. For example, if we do offer lumpectomy and you're in certain parts of the country, there may be significant distances that the patient may have to travel to get radiation. And they may say, you know what, I can't go somewhere Monday through Friday for 5.5 weeks and I don't have a ride, I don't have the support system, or it's too much. So I may choose a different option, it's not a wrong option for a woman to undergo a mastectomy and have that treatment choice. And then the thing with screening earlier, you sometimes do detect disease that does not end up killing a person, and that's not necessarily the only endpoint that we worry about, but certainly their survival is often the number one thing and that we discuss. But there are many others disease processes, and one in the world of breast cancer that I know a little bit is ductal carcinoma in situ, or cancer that's still inside the ducts. Not all DCIS becomes invasive or goes outside the ducts, and not all invasive breast cancer, go to lymph nodes and spread to other parts of the body. So do we need to offer these, more extensive therapies or treatments for potential patients that, the disease process does not spread? And there's still a lot of work to do with that. And then when you screen early and often, you may be seeing more of this type of, disease like ductal carcinoma in situ, or cancer like ductal carcinoma in situ, and that not all of it needs to have significant surgical or radiation or even drug therapy treatment. Some can actually be potentially left alone and observed. And that's kind of the maybe the other extreme. Is one is you can catch it early and avoid some of the treatment toxicities that for example, I had to go through with colorectal cancer. I had a year's worth of chemotherapy, chemoradiation, and surgery, and it not only knocked me out, but it certainly made it so incredibly difficult for my family, my wife, my kids, my support network. The toll goes well beyond the patient themselves, or him or herself. And if you can catch it early and potentially not have to go through these extensive type treatments, it's not a bad thing, trust me.
I want to remind everybody, please, if you have questions, I'm going to kind of open this up a bit more. We're going to field questions to both Mara and Elaine. So if you have questions, please put them into that Q&A box, and we will get to those. Elaine, did you want to add anything regarding that?
First, I agree with most of what Mara said. I would really add just some points that, besides, I also am a cancer survivor, and yes, it definitely is better to have less treatment than more treatment. And one thing that I think is often goes unmentioned by journalists are the costs of treating late stage disease versus early stage. So yes, I know personally how much better it is to have less toxic treatment, but also the cost of treating stage 4 disease is extreme. New cancer drugs are running between $16,000 and $20,000 per month. Many people get more than one drug, and those costs are unsustainable. And so there's an economic argument that gets overlooked about the benefits of early detection. Now, the problem is, as Mara indicated, and you all know, there's a risk of overtreatment. And the way I see that is that if we could do a better job of educating doctors and educating the public that people won't freak out about having cancer, that that would reduce overtreatment, because there are many tumors that could simply be excised removed surgically, or treated with a little bit of chemo, or a few, less is more sort of approach. And so I think that the leadership in oncology now, for the most part, is working to look at lower doses of medications. Part of the problem there is some of the drug companies only make available high doses, and then that becomes expensive in itself. But I think there's a significant move, if you will, among oncologists to give less intense, less toxic treatment. And I think that will become more and more important as we detect more cancers with new blood tests and stuff like that.
And echoing on what she just said, I completely agree, is that, as journalists or, as a patient population, is to question and, the drug companies, because they do a lot of great work with developing remarkable treatments that did not exist in the past. But I work for a non-for-profit, I'm a salaried employee, there's a reason why I went into medicine. And sometimes that is lost upon some of these companies, where they will want to try more and longer durations to see if it's as good as what they think works now, as opposed to potentially de-escalating and trying a shorter duration of treatment. And I think that's something that is well worth questioning.
Thinking about that, this kind of gets at the heart of what I think is challenging for me as a reporter, and I'm sure others can relate, is on the one hand, you have, I think, a substantial number of people who don't realize just how good a lot of our cancer treatments are and how far advanced they've come. They still see the big C as this really scary thing and don't realize the options they might have. And we think about hearing for the cure of cancer. We have a lot of cures for cancer right now. At the same time, you don't want to give false hope, especially if they develop a particular type of cancer for which we don't have those advantages. That, some cancers are much further ahead than others. Some are outright curable, and some we have very little treatment at all. How do we as journalists, and I guess even as clinicians, adequately and I guess responsibly educate readers on just how many options are out there without giving that false hope and making it sound like everything's all fine and good? How do we strike that balance? I guess I should have specified who. I'll start with Elaine on that one, and then
All right.
Mary, if you want.
Yeah, so that's a tough question, Tara. So I don't have a simple answer. The case with Jimmy Carter being a good example of, I might have shied away from giving the former president treatment for metastatic melanoma at the age of 90. But he was in generally good health and he wanted it. You're asking about how to inform the public through journalism about new drugs and all the options. I spent a number of years writing for Forbes as a contributor, and there I noticed that what was valued a lot was traffic, as is the case in many journalistic websites. And I've also written for other outlets where I think the stories that fly tend to be, unless they're about a particular drug and investors click on it, potential investors, the stories tend to be simple. And to the real nitty-gritty that patients want to know is rarely available in mainstream journalistic outlets. And so while I was doing that reporting for Forbes, I tried to get into the nitty-gritty of new breast cancer drugs. I found it interesting, and so I did that. And the fact is that there's not that much traffic, and there's not that much money in that sort of reporting of details of like the newest PARP inhibitor and how it might compare to another one. It's not how journalism works for the most part, unless there's a new drug and a company that people might invest in. And that's unfortunate for patients. And the interesting thing was that I think the patients have taken it upon themselves to share these data and this kind of information. So if you go to the advocacy websites or Facebook pages, you will find a lot of information on new drugs for lung cancer, for instance. And you'll have, groups centered around, particular mutations that people may inherit or mutations that occur in the cancers. And there are people who aggregate online and share tips. They share their experiences with toxicity from drugs. And in fact, biotech investors look at those Facebook pages to see what's going on with the drugs, how well they're tolerated. That's a whole issue. For patient privacy, among other things. But my point is that the advocates are really providing information on those things among themselves. And then I think some specialty doctors. So if you have a cancer doctor who is only, a medical oncologist who only does lung cancer, they may be really expert in those drugs, but you're not going to find that in a journalistic piece. And I think, unfortunately, it's really hard for a journalist to tackle that. Plus, there are a lack of comparative trials now that there are so many Me Too drugs, which I'm not necessarily against. There are very few trials comparing those head to head because no company will sponsor, or few companies will sponsor those kinds of studies. So, and by the time those studies, if they're randomized, are done, there are newer drugs out there. So I think that ultimately artificial intelligence will provide, I really do think this will provide patients with like sort of the best set of their current options and what's known about them. But I don't think any human doctor or journalist can keep on top of everything. I just don't.
I agree with the, especially when you get into the nuances of treating a patient with a particular cancer or an advanced cancer. In this case, is that, there may be, you may be able to report on or discuss maybe some standards or first line and second line therapies, but there are so many nuances and branch points that getting into the details may give either false hope or take patients down and their families down the wrong direction, or a direction that's not applicable or even available for that individual.
I just want to jump in quickly, and I see we do have a couple of questions coming in. So Elaine, you and I talked about this a little bit earlier. ASCO came out with some new recommendations yesterday, I think it was, about doing a geriatric assessment for older people in terms of determining treatment. So I wonder if you could just, both of you could just address that. And we are running a little short on time, but if you don't all mind staying a few extra minutes, I think we can get the questions in.
Sure. Yeah, well, as you pointed out, this week, the American Society of Clinical Oncology, which is a group of medical oncologists, doctors who give chemo and immune therapies, medicines, came up with new guidelines for treating cancer in the geriatrics population. And the first author on that was Dr. William Dale, who's a terrific source, in my opinion, on that subject. And basically, there are oncologists who specialize in treating cancer in the elderly. And there the equation, you have to weigh things differently than in a younger group of patients, because people are more frail overall, and they're more vulnerable to toxicities of treatment. They're more vulnerable to complications of surgery. They're more vulnerable to complications of radiation. And they're in general more vulnerable to toxicity from medications that affect, say, the liver or the kidney. And so I think oncologists, and this is part of our training, have to be really careful when you prescribe cancer drugs or any drugs to older people. That said, some people are in their 80s or 90s and really living full active lives and maybe physiologically younger than like someone who's had a lot of medical illness before. So unless we start talking about rationing, which is a separate beyond this webinar, I don't think we can. I think doctors have to use judgment, clinical judgment, in the treatments they give. That's the gist of it for patients of any age.
I was going to try to tackle a couple of the questions that popped up. One was on the role of new screening, like, for example, 3D mammography or ultrasound. And in overdiagnosis and other, for example, other technologies. So the great news is breast imaging has become a lot better. So from what was called 2D to tomosynthesis or 3D mammogram. Some states, I'm in Connecticut, there is availability of whole breast ultrasound as part of screening that's available to women. There are women that, for example, that are at really high risk of developing breast cancer, who may also be supplemented with MRI. We definitely do find more abnormalities, but they're also more precise in being able to tell what is and what isn't benign. I guess we usually have to do disclosures up front. I'm actually married to a breast radiologist, so certainly, I would defer to them in terms of expertise. Yet with 3D mammography, whole breast ultrasound, things like breast MRI, we can look and find things at an earlier stage, which in general will go to better outcomes. The question ends up being, for example, who are the ones that would be better served with the additional screening adjuncts such as breast MRI, and knowing that there would be potentially more false positives in that patient population. And then there's, I think, a question about the challenges to the Affordable Care Act, or ACA. And there's been a lot of work and literature that has come out from different physicians and groups with different aspect, one in breast cancer and in other malignancies, with a lot of the screening modalities that have been afforded by the ACA. And most have shown what happened, before Affordable Care Act was available and then afterwards, and most will show a benefit for sure in terms of outcomes, earlier stages of detection. And I would see that would be reversed in cases where that falls away. And it's something that, I came from before Connecticut, Massachusetts, and that was truly the first kind of state that had access to healthcare for all. And we definitely saw that in the greater Boston area where I was before, and we've seen it on the national scale with the ACA.
I might add to that point, or those points, that mammography is not just one thing. And so in terms of journalistic coverage, a point that I've made many times, and Mara, you may have as well, the quality of mammography varies. So Mara mentioned 2D and 3D mammography. 3D is now the standard of care, but also the quality of ultrasound varies. The quality of MRI even varies in terms of who interprets the MRI, who reads it. And even with the AI, if you have a radiologist who is more experienced or just better, at discerning images, that will influence the incidence of false positives, false negatives, et cetera. And I think it would be helpful to women who are, to make more informed decisions about when they should start screening, to learn more about where they should start screening. What are the qualities of a center where they can get a good quality mammogram, a good quality sonogram, et cetera. So I think that issue is overlooked. At the population level, there are many places that offer mammograms that aren't particularly good at, where maybe a general radiologist who reads that. And, for me, I would never, and this was when I had breast cancer, it was 2002, I never would have gone to a general radiologist even then to have my breasts imaged.
Yeah.
No way.
Yeah, I agree with you completely. There is so much data for better outcomes when you go to people in places that do the same thing day in and day out for example, breast imaging, or at our center, maybe pancreatic cancer surgery, things along those lines. Not everyone can get access to places like this, so certainly if getting a general radiologist is definitely better than not getting imaging, but making sure that or scrutinizing or asking questions in terms of who is doing your study, who's reading them, how is it being interpreted, what is the type of equipment that they have available. Absolutely. You go to a car dealership or whatever, and you ask, much more detailed questions. There's nothing wrong with, challenging me in terms of the number of cases that I've done, what are my outcomes, and things along those lines. So absolutely, we are, much better advocate for, ourselves, and we absolutely have to do that.
So we only have time for really one more question. We've got a couple of minutes. So I wanted to throw out a question that came from our audience about genetic testing. What's the sentiment about that now? And is this a good idea? Is it not a good idea? Will insurance, pay for the probability of it, even if you're not in a high risk group? Well, where do we stand on that?
All right, shall I answer? All right,
Sure.
so first,
Sorry.
okay, no, of course. So personally, I'm wary of genetic testing at the population level, and that people will end up having too much, people will live in fear, and also that they'll end up being overly diagnosed due to so much screening. For example, I'm aware of certain advocacy groups where even children are screened for cancers because they've inherited some mutations. That's sort of extreme. The sentiment among doctors is pretty gung-ho, and maybe that's why I'm so wary. And there's also a lot of investment in genetic testing companies. So I think there are a lot of angles of the story on that. I'm personally wary. I think, though, where I'm not is there's a big difference, which I hope everyone realizes, between testing of the DNA you inherit to see if you have a mutation that's cancer disposing, and testing of the tumor. So once someone has a cancer diagnosis, in my opinion, it would be foolish not to have that evaluated as fully as possible to see what treatments are likely to work, so-called to look for targeted matching drugs, which are way more likely in general to be effective than some of the, depending on the tumor type. To not inform patients of that pathology, to me, is really morally wrong. Like, essentially, there's more information that we could provide people about, and their doctors, about their tumors. But because for insurance or for just skepticism, people don't run those tests. To me, if someone has a cancer diagnosis, they should have as much information as possible about the kind of cancer they have. Now, and I just want to go back for 1 second. It's not that I don't think people should be genetic tested for, say, BRCA or Lynch syndrome and other things, but I think if we have a whole population that gets a lot of genetic testing, we're going to end up with a lot of disease, both known because people recognize symptoms that they wouldn't have noticed otherwise, and also because we're going to end up treating people for preconditions, and that scares me a lot. Yeah. So to me, a diagnosis is reason to test more than before the diagnosis, if that makes sense.
And, building on what you just said, so again, there's the genetic testing for predisposition to a malignancy or a syndrome or things along those lines. And that's usually a blood test, and it's sent to one of a handful of companies. It used to be one company, Myriad Genetics, and that led to a Supreme Court case where then it opened up testing to other. I think the question, whether it is on the genetic testing for predisposition or even the genetic testing of the tumor, is that there are things that can be identified that are currently not actionable, meaning that it may show a mutation or a break, but we don't have anything that can treat it. Or if it's in the predisposition category, we don't know exactly what that's going to, put that patient's risk at. And that also is something that, has to be explained, to the patient as well, meaning that, you may get testing, you may get this thing called an uncharacterized variant, or if they test the tumor, there may be some, mutation that has been identified, but we don't still have a targeted treatment for that malignancy. So there are some, downsides to both, yet there are many reasons why you should get your tumor tested, and for certain populations that come in to have genetic testing for predisposition to a cancer or malignancy.
Well, I think we're going to have to leave it there. We do have a couple of other questions in the queue. So could we give out your email addresses if people have follow-up? Elaine, would you like to share
Sure,
yours?
of course. Yeah, I'm happy to speak to it or
Okay.
write to it.
So it's elaine.shatner@gmail.
Yeah. Yep.
And Mara?
Yeah, for sure. You guys can call me, cell phone, email, mehra.golshan@yale.edu.
Wonderful. I want to thank everybody who tuned in today. Thank you to our two excellent panelists talking about breast cancer. My mother unfortunately died of it, so I have a personal connection to this topic too. And I think it's really important as journalists that we report responsibly and talk without the emotion, but without also giving false hope. There's a lot we can do, and there's a lot more still to be done. And I think our role as journalists is to facilitate the conversation. So thank you both again. If you want a recording of this, it should be up on healthjournalism.org in a couple of hours. And AHCJ will continue to bring you webinars on a variety of health topics as a perk of your membership. And thank you, Tara, for being a terrific co-host.
Thank you, everybody.
Thank you, guys.
for having
us. Thank you.
Thanks for having us.